9 to 20 in Hawaii's communities. The SEOW is a partnership between the Department of Health, Alcohol and Drug Abuse Division, or ADAD, the University of Hawaii, and interested community stakeholders. The SEOW has been providing epidemiologic services to ADAD since 2006. The SEOW collects, analyzes, and reports substance use incidents and prevalence, as well as provides technical assistance and training for state and community stakeholders. As part of the SPF-PFS, the State Community Partnerships Workgroup, or SCPW, supports academic and community partnerships that increase the capacity of substance abuse prevention system to address local needs. The SCPW achieves this by conducting applied research which address alcohol use among high-risk populations. The SCPW supports the goals of the Hawaii Strategic Prevention Framework Partnership for Success, or SPF-PFS. So that is a quick background on the SPF-PFS project, the SEOW, and the SCPW. There are just a few reminders we want to go over before getting started. So we're using the Zoom webinar format, which may look a little different from the Zoom meetings format that you may be used to. Attendees are muted and videos are off. So presenters and hosts are not able to see attendees, and attendees cannot see themselves. So if you have questions, please send them through the Q&A feature located in the bottom middle of your Zoom window. And you don't have to wait until the end of the presentation to submit your questions or comments. Please send them in at any time and we'll review them at the end of the presentation. If you would like to wait until the larger discussion at the end of the presentation, that's also totally fine too. So without further ado, I'd like to hand it over to Dr. Okamoto.
Good morning, everyone. I'm going to go ahead and share my screen. Hopefully this will work. Try to go into okay. All right, so thank you everyone for attending this presentation. Thank you for the opportunity to present some of our research. The title of my presentation today is Implementation Barriers and Facilitators for School-Based Substance Use Prevention on Hawaii Island. And so I'll go ahead and get started. So in terms of the background and significance of this study, there's been research and anecdotal evidence over the past several decades, actually, that have indicated that interventions, and particularly prevention interventions for drug prevention, have been haphazardly or poorly planned and implemented in communities. So this research really started in the late 1990s, and unfortunately, not much has changed up until now. Some of our anecdotal evidence in collaborating with our community collaborators and partners on Hawaii Island have pointed to systemic issues related to the implementation, adoption, and sustainability of prevention in public schools. Superintendents, principals, teachers that we've worked with have talked about how, for example, interventions will pop up in a school and be well received in those schools and be implemented for a certain amount of time, and then they'll disappear and they'll show up in another school without any sort of reason. And then those interventions sort of just disappear when funding dries up. So there's really just sort of this anecdotal evidence, which really sort of validates what some of the findings were in the late 90s. So things haven't really changed a whole lot. And so that sort of serves as the foundation for the research that we've been conducting in implementation on Hawaii Island school and on Hawaii Island. More broadly, there is, the field of implementation science is relatively new, and there's not a whole lot that really has been, published relatively speaking, in the field. And so there's a lot to know still. And, there's a lot to understand more in terms of measurement, how to measure factors in implementation. There's also a lot of information that needs to be known in terms of implementing interventions in novel settings outside of healthcare, in rural settings, and with diverse communities and populations. So that's sort of the backdrop for our research that we've been conducting over the past several years. So the purpose of this study is to examine implementation determinants, which is a category that encompasses both implementation barriers as well as implementation facilitators for school-based prevention on Hawaii Island. And to examine this, we're using our school-based culturally grounded substance use prevention curriculum called Ho'oponopono as the vehicle to understand implementation determinants. Secondarily, the purpose of our study is to describe the process of developing an implementation adoption sustainability inventory in order to contribute to the field of implementation science and understanding measurement. And both of these purposes are framed under the backdrop, the theoretical framework of the Consolidated Framework for Implementation Research, or CFIR. The CFIR is currently undergoing a major revision. It's in its second iteration. So a lot of our analyses we'll be talking about today really contextualize the findings along the latest version of the CFIR 2.0. So let's talk a little bit about the CFIR 2.0, which the website is on this slide. It's a comprehensive framework of key domains and constructs which inform implementation research and practice. And there are 5 domains. These domains include the innovation, or the thing that's being implemented. And in this case, it's Ho'oponopono, our substance use prevention curriculum on Hawaii Island. The individuals that are responsible for implementing those interventions, and that includes both the characteristics and roles of those individuals that are responsible for implementing the intervention. The inner setting, which is the setting in which the innovation is being delivered. So in the case of our study, it's within the schools, but it could be within a hospital, it could be within a community-based agency. But for our purposes, we're looking at the intervention being delivered in the schools. The outer setting is the context and the settings in which the inner setting exists. So for our work, it's the school complex area, it's the state of Hawaii Department of Education, it's the federal national Department of Education. So there could be multiple outer settings and with varying scopes. And then the process, which is basically the process with which the innovation or the intervention is being delivered, the steps with which is the intervention goes through to be delivered. So let's talk a little bit about Ho'oponopono, our intervention that we've been developing on Hawaii Island. So this intervention was developed through a multi-university and community partnership. So initially our work was a collaboration between Hawaii Pacific University, where I started this work, the University of Hawaii at Manoa, in particular the John A. Burns School of Medicine, and our community partners, which were the Prosecuting Attorney's Office on Hawaii Island and the 3 school complex areas on Hawaii Island through the Department of Education. The development of Ho'oponopono was, and evaluation of the curriculum was funded through 4 NIDA-funded projects that really spanned the pre-prevention stage to look at the contexts and the situations with which youth were exposed to that involved the use of illicit substances. We created a pilot version of the intervention and tested that in R34 grant. We scaled that intervention and tested it across a wider array of schools in our efficacy trial on Hawaii Island. And then currently we are examining the implementation of the intervention across schools on Hawaii Island. The curriculum is a school-based video-enhanced intervention that is based on interactive principles and active learning. It's teacher implemented. So we train teachers in the use of the curriculum through an in-person training, as well as provide implementation support through a website. And the website is also used for monitoring fidelity of the intervention. And we've aligned the intervention with the state and national standards for health. Right now, we're undergoing a transition from the Hawaii Content and Performance Standards in Health to the National Health Education Standards published by the CDC to align with the adherence of the CDC health guidelines in the State Department of Education. The research design we used was a formative mixed methods design using our educational collaborators and partners on Hawaii Island. So the first part was conducting in-depth individual interviews. We conducted 24 of those with educational partners on Hawaii Island, and then we extracted items from those interviews, created a survey, and that survey is currently being implemented in across Hawaii Island schools, as well as across the State Department of Education on Oahu. And so far, we've collected 197 of those surveys. And so that's what I'm going to be presenting primarily today. So in terms of our semi-structured interview schedule, we asked questions such as, what can be done to further promote Ho'oponopono's alignment with teachers' professional and educational needs? That's really focused on the intervention, or in this case, the innovation and its adaptability to the Department of Education. How do local, state, or national performance measures or policies influence the implementation of Ho'opono? So that has to deal with the outer setting in terms of the policies and laws at the local, state, and national level. Which teachers should oversee the implementation of the curriculum in your school, and why? That has to do with the inner setting and particularly the work infrastructure within schools. How confident do you feel about implementing Ho'opono in your classes? That has to do with the individuals that deliver the intervention and their capability to do that. And then who do you see as a lead person implementing the curriculum in your school? That has to do with process, and in particular the teaming process and the roles within the team to execute the intervention. Okay. This is what the paper and pencil version of our survey looks like. We also have an online version that looks slightly different. The layout's slightly different, but the information that we're collecting is all the same. So we extracted 50 different barriers from our interviews with our educational collaborators on Hawaii Island. And then for each of those barriers, we asked, how much does it impact the implementation, adoption, sustainability of our curriculum, and how difficult would it be to overcome each barrier in Hawaii Island schools? And so this is just a few of the items, but they span from things like looking at natural disasters on Hawaii Island and their impact on school-based prevention efforts, to looking at community norms around marijuana use. That's number 4. Looking at turnover of state level administrators, that's number 5. So it really spans, tries to span a lot of different contexts and levels that would impact implementation. So the second part, so the whole first part looked at the barriers to implementation. The second part of the survey really looked at facilitators, things that would promote the use of the curriculum. And so what we did was we extracted 27 facilitators from the in-depth interviews, and we had survey participants select their top 3 and rank order their top 3 in terms of their ability to promote the use of the curriculum in public schools. And so these are, a lot of them match to the barriers, but are framed more positively. Some of them are unique. They go from looking at outer setting based issues, such as the emphasis on the state superintendent's emphasis on student voice and the whole child, to looking at things such as providing teacher training and the intervention for free, things again at various levels that would help encourage and facilitate the use of the curriculum. So this is a quick description of the participants in both the in-depth interviews and in the surveys. And so mainly for the in-depth interviews, about 50% were female, about 50% were Caucasian, and there were pretty much a balance of superintendents and principals and VPs, so upper administration and teachers in the interviews. For the surveys, the survey participants thus far are predominantly female. They are over 50% Caucasian and over 30% Hawaiian, part Hawaiian. We have predominantly teachers that have taken our survey. And for both the interviews and surveys, most of the participants have some form of graduate degree. Okay, so I'm going to go over the results at this point. So what we did was, of the 50 barriers to the implementation, adoption, and sustainability on the survey, we rank ordered them. And these are the top 5 or the top 10% of those that were selected by the participants. And so the one that was ranked the top was that the Ho'oponopono curriculum does not extensively cover current or recent forms of substance use, such as vaping. So that was the highest mean scored item that has to do with the innovation or our intervention in terms of its adaptability. I have an update on that. We'll talk about that a little later in the presentation. The second ranked item, some HIDOE teachers are resistant to trying new curricula like HP because it feels like, quote, one more thing you administrators want me to do in the classroom. So that has to do with the individuals, and particularly the intervention deliverers and their motivation for using our curriculum. The third ranked barrier is there's a lack of HIDOE funding to support prevention curricula like HP. This has to do with the outer setting, specifically in terms of financing. The fourth ranked item, the implementation and training related to the HP curriculum will be difficult to fit into teachers' busy schedules. That has to do with the inner setting, structural characteristics, and particularly the work infrastructure within schools. And then the fifth item is that the delivery of the HP curriculum is assigned to a teacher who is resistant to using it. That has to do with the individuals delivering their curriculum and their motivation. Okay. Whoops. In terms of the most difficult barriers to IAS, they mirror largely the ones that were considered most impactful. So for example, the first item is having to do with the one more thing you admin want us to do in the classroom. That was the #2 item for the impact. It's the #1 item for the difficulty in terms of overcoming this sort of attitude. And 3 of the top 5 actually had to do with the intervention deliverers, 2 of which had to do with their motivation to deliver their curriculum. 1 has to do with their capability in terms of translating lessons into Hawaiian for Hawaiian immersion schools. And then the third item has to do with funding. And then the second ranked item has to do with fitting implementation and training into teachers' busy schedules. So a lot of the same items that rose to the top for difficulty. So for this chart, what we're looking at are the highest ranked facilitators. So what we're looking at here are the ones that participants ranked as number one, or the top ranked facilitators. And far and away, the top ranked facilitator, 1 out of 5 participants in the survey indicated this is their top ranked facilitator, is that the HP curriculum is place-based and focused on the local culture of Hawaii Island. That has to do with the innovation and its relative advantage to other approaches to dealing with substance use prevention. The top 3 actually have to do with that, right? It has to do specifically with the innovation, the intervention, and its relative advantage to other alternatives to addressing substance use and youth substance use. The number 4 one has to do with the innovation cost, that it's free upon receiving training to use the curriculum. And then the 5th one has to do with the state superintendent's emphasis on student voice. So focused on policies and laws in the outer setting. So with regards to that top ranked facilitator, this is what one of our participants in the interviews stated. And so what he stated was, quote, "I thought that they," and they in this case were the videos that are used as part of the curriculum. So he wrote, "I thought that the videos were very good. I was very impressed at the level of the kids' ability to come across genuine in the videos. And of course, the way in which Matt, the director, put the videos together. The way they were scripted was very genuine, and the youth actors did a great job of that, of course. And that, of course, will bite right into the other kids as they watch it, because you can really feel the emotion when you're looking at them. And I love the cross-section of where the vignettes occurred. I mean, awesome, awesome, awesome. I mean, a lot of the time, people don't want to talk about what's happening at the house and the party on the weekend. And so those were excellent. So that's sort of an example of what a lot of the participants in our interviews described, and really was illustrative of sort of the place-based and culturally grounded nature of the intervention. So in terms of conclusions, there's several takeaways that we have thus far. Financial resources seem to be a major consideration in the implementation of prevention. So the major barrier, both in terms of impact and difficulty, is dealing with the lack of funding at the state level for things like prevention. And a facilitator of using our curriculum would be that we don't charge for that, for the use of it. Role conflicts between administrators and teachers seem to present a significant implementation barrier. So this whole idea, right, of, you know, administrators just pile things on for us to do things, and we don't want to do more stuff for the same pay, right? So there's this sort of conflict that administrators and teachers and faculty have. And so sort of looking at that and addressing that in the implementation of curricula and prevention curricula is important. And then in terms of facilitation or facilitators, intervention characteristics seem to be really key, that if you design a curriculum that really meets the needs of rural communities and local communities, that really is a draw and something that promotes the use of something in the schools like a drug prevention curriculum. So next steps, where are we at now? So we're trying to finish our survey data collection. So I was hoping we were going to be done completely, and I was going to be able to present more complete analytic findings for our survey, but we're not done yet. We're getting close. We need to get over 200, and we're like at 197. So just really a handful more. If anybody on the call has recommendations for us of HIDOE state level folks or folks on Hawaii Island, we really would love to get those names. Even more so if you could reach out to those folks and let them know that we're going to be contacting them. That's even an additional step that would encourage their participation. We would really love that, because we just want to sort of get the survey data collection wrapped up. Once that's done, we can do some more advanced psychometric data analyses. We really want to look at doing exploratory factor analysis to see how these items cohere together and if they reflect the CIFAR domains. We also want to look at analyses comparing administrators to teachers potentially, or looking at different geographic areas to see if different geographic areas on Hawaii Island rank certain facilitators and certain barriers differently. We have a colleague, or our team has a colleague, Kelsey Okamura, who is doing a parallel study with using a approach called concept mapping with state level HIDOE folks that is looking at the survey items and having them cluster those items and mapping those items using a specific type of software. So the survey is really looking at it from the top down, starting with the CIFAR theory and developing items and analyzing it from a top down approach. The concept mapping approach is more of a participatory and interactive approach with folks to see how the domains, the different items cluster in specific domains. And, we want to kind of see how they converge, right? If folks in the DOE think items group differently than our survey data seem to suggest. The whole idea behind all these analyses are really to help develop regionally tailored implementation, adoption, and sustainability action plans for the different areas on Hawaii Island. And going back to the first barrier, which looked at that really indicated that the curriculum really needs to address novel and emerging substances. We were just recently funded to do an adaptation of Ho'oponopono to really incorporate more e-cigarette and vaping content. And so we're in the process of updating the curriculum, updating the website, scheduling focus groups to get new data, to create new videos, and to create new lessons, to conduct a new trial that focuses on ENDS use or e-cigarette use. And so that's it for our presentation. And I guess stop sharing. Oh, you're muted.
I'm so sorry. Thank you. Thank you, Dr. Okamoto, for your presentation as well. We're just going to move on to questions. So if you have any questions or comments about the presentation, go ahead and use the Q&A feature, or you can also raise your hand and we can unmute you.
Okay, it looks like we have one raised hand. Sarah Ewan, I'm going to unmute you so you can ask your question.
Thank you. Thank you, Scott. It's great to hear from you and hear the updates about the project. So with all the barriers that you mentioned, I wonder, and I know you guys are, in the process of matching up your curriculum with the national, standards or the curriculum directions. And I wonder how you see the possibilities of integrating this important content into a regular health education curriculum, so that the teacher will feel that this is a part of their work, and then there is, this prepared, well-prepared content for them to implement.
Yeah, so that's a really good question, Sarah. So ultimately, right, we've been moving towards we've been understanding more about teachers' needs through our work and collaborating with schools on Hawaii Island and public schools in general. And really what these schools are looking for is something that is adaptable and tailorable to their own needs. every teacher teaches differently, and they want that. They want to be able to take something and put their own stamp on it. Nobody wants to just take something and just kind of, you know, follow the steps of the recipe. Everybody wants to tailor things to what they feel are the specific and unique needs of the kids that they serve in their own communities. And after collaborating with the different communities across Hawaii Island, we can kind of see why that's the case, because every community is very, very different, and every school actually operates very uniquely. And teachers emphasize different things based on the specific needs of their communities and schools. So we've tried to incorporate that more and more in our work. You know, for example, we don't say you have to do this intervention in this specific way, in this specific order, in this specific timeline. You know, it's really sort of an adaptation and consultation with specific schools in terms of, okay, how do you deliver this content in the way that is the best fit for you, your school, and your students and your community. And we've had to do a lot of really creative things that have been challenging, but ultimately, I think, provided more value to the curriculum and ultimately sort of supported and enhanced the curriculum's implementation. So, and with our new intervention, or the update with the e-cigarette content, we're trying out something new in terms of what we're calling modularity, which is having teachers select exactly how they want their intervention to look and the topics that they want to cover in their intervention. So they can, if there's an issue, for example, with bullying in their school, there's a video and lesson content that looks at bullying and substance use together. And so they can draw that one down and use that one in their curriculum. But if that's not an issue, maybe it's more teen dating. There's one that's focused more on teen dating and substance use pressures to use substances in dating situations. They can pull that one down. And so we're kind of exploring with sort of trying to embrace that customizable and that you know, variability in that the teachers want in each of the schools. So I don't know if that really answered your question, but that's sort of how we're sort of trying to approach it now.
Yeah, that's very good, and thank you. And I really think that this is very interesting, and potentially, you know, we can learn a lot from this kind of adaptation process, right? And you know, even with the curriculum, you know, the evidence-based curriculum that people implement in the communities, you know, there's a lot of, you know, adaptation going on, and a lot of time it is not captured, right? So it's just that we don't know. People tend to, you know, do things that they think is more suitable for their audience, right? Which is rightly so, right? We just don't have a lot of data in learning how that adaptation works or not working. So I think, yeah, this is really, really great that you guys are keeping track of this adaptation and, you know, learning the process and learning how people actually implement the curriculum. Yeah, thank you.
Any other questions? If not, I'm willing to turn it over. Well, so my email, my contact information is up, so feel free to reach out if you have any questions after the presentation. Thanks.
Great. Thank you again, Dr. Okamoto, and thank you, Sarah, for your question. We're going to take a 10-minute break to give us time to transition to the second half of the meeting. So feel free to stretch, relax, get some water. We'll see you back at 9:48. Hey, welcome back, everyone. All right, we're about to begin the second half of our quarterly meeting, so please join me in welcoming Dr. Michael Phillips.
Hi, everyone, and thanks for being here. I'm going to see about sharing my slides here. All right, so just a few little things here. Today, I'm going to kind of talk about alcohol, tobacco, and cannabis use in Hawaii. And really, this is exploratory because we're kind of looking at the 2020, 2021, so kind of hot off the press, or I guess hot off the keyboard. And so some of this, we are looking at the co and polysubstance use based upon the preface. And so want to thank the SEOW team. Micah, Laura, and John have kind of all helped kind of pull some of this together for today. And so just wanted to thank them and say, appreciate your help. Okay, so let's see. Just a little overview. I'm going to do really just a quick introduction of some of these things and talk about some of the factors and risks and harms associated with co and polysubstance use, and then get into some of the 2020, 2021 prevalence data really for polysubstance use across all three of these, and then co-use and then singular use. Well, I'll start by looking at I'll start by looking at the whole age spectrum across everyone, and then kind of zero in on the young adults subpopulation, really, because that tends to be an area that for prevention and prevention intervention, we like to think about and kind of focus on for some of that. And then kind of look at some of the co-use combinations across these three substances. Then talk about some of the exploratory kind of predictive models that we've kind of started to do with some of the co-wise substance use, and then also mental well-being and depression, some of those questions that the breakfast hand asks. So for today, for the scope, really kind of focusing in on tobacco, and I'm going to say tobacco nicotine, partly because we looked at combustible, non-combustible, so vaping, and then also some of the other like chew and stuff, and some of those questions I get asked. And then alcohol and cannabis. And partly these are the three most frequently used substances across the US and also in Hawaii. And so we kind of zeroed in on looking at co-use and poly-use for these. We have started to kind of work with the 2020, 2021, the Behavioral Risk Factor Surveillance Survey. And so I will kind of make note of some of the things and limitations with working with the most current data. And so that's something that will come up when we kind of get into talking about some of this a little bit. Well, so we're going to talk a little about co-use and polysubstances, and this becomes important to kind of think about the time frame and how time plays into how we discuss co-use or polysubstance use. So why is time important? Well, because co-use can mean different things depending on the time frame. If we're asking questions, and in the past year, have you used, I don't know, let's just say all three of these substances, and someone says, yes, I've used these in the past year. Okay, well, so we would say this is polysubstance use, but these things might not be happening at the same time. It might have been, you know, they had some alcohol drinks like at the beginning of the year, but then they decided not to drink the rest of the year. And then, you know, they're a current smoker that's smoking every day, and they had a cannabis joint in the summer. So now, because of kind of those one instances of use throughout the year, we would say that's polysubstance use. Or we could look at past 30-day use and look at that time frame and see, okay, how does the past 30-day co-use or poly use kind of happen? And so the time frame really does make a difference in how we talk about some of these things. And so with the preface, a lot of this is asked in the past 30 days. And so I'll kind of make note of that. The tobacco and nicotine questions, the way that they're asked makes this a little difficult and a little tricky. So that'll come up with some of the limitations before we get into the data. Some really interesting things to think about is what is called kind of concurrent, what we were talking about, like, well, it could be back-to-back days where someone had cannabis, they were vaping on Friday, and then on Saturday they went out and they were drinking, you know, in a social setting and having some drinks. And so that would be concurrent. We have back-to-back days. And so we're not having these overlapping intoxication or effects of the substances. So that's what we think of as simultaneous or maybe sequential use of, you know, they're in a situation where they're using both of the substances or all three of the substances, maybe, you know, kind of like back to back to back. So, you know, or maybe they're having some alcohol drinks, and in between some of the drinks, they're also kind of partaking in the cannabis, and also then, you know, maybe smoking some cigarettes in between as they kind of step out. So maybe this is all over a couple-hour period. So that's the thing we would say this could be, you know, overlapping aspects. And so this kind of idea of like same day, same hour, you know, this overlapping intoxication becomes an important thing. With the preface data, we don't really know if it's simultaneous use. Kind of the best that we can kind of say is that we know that there's at least concurrent kind of happening within the 30-day time period. Well, why focus on co-use and polysubstance use? Well, some of the reasons, you know, when we start to look at co and polysubstance use, the risk factors and some of the harms start to kind of build and go up as we start to see the use of multiple substances. Now, again, we're looking at the three kind of most common substances, and, you know, someone could make an argument, well, it depends on the substances that are being co-used or poly-used. And I would say I completely agree with that. So some of the things that I'm going to list, you know, might depend on, you know, the substances that are being co-used, but all three of these substances have been actually kind of connected to some of these risky behaviors or harms or negative consequences. So things like, you know, worse mental health and physical health, greater chances for unprotected sex, injuries, you know, violence or dangerous driving, self-harming behaviors, involvement with the legal or criminal justice systems, higher rates of high school dropout, especially when we start to look at, you know, adolescent co-use, poor treatment response. So some of this, especially, there's been research using the National Epidemiological Survey on Alcohol and Related Conditions that finds that when someone is actually or has a substance use disorder, they're more likely to have a co-occurring substance use disorder for another substance or an alcohol use disorder. And the prognosis tends to be worse, you know, as compared to like one single SUD kind of diagnoses. So the other is around patterns of co-use and poly-use tend to increase over adulthood. And so some of the problems tend to become exacerbated, you know, as individuals that start co-using in early emerging or early adulthood, these things can kind of exacerbate as individuals get older. So it's really important to identify some of the characteristics and patterns of polyuse to really target some of the prevention and prevention intervention programs and strategies towards individuals. So it's really important to kind of be assessing and thinking about co and poly use. All right, so the focus for today is really going to be kind of at some of the prevalence of singular co-use and polysubstance use in Hawaii, and really focus on the 2020 and 2021 data. And so going to look at by age and sex, and then kind of look across the lifespan at some of this, and then kind of zero in on young adults. And we can have, does 18 to 29 kind of capture the young adults? Well, it depends, I guess. The farther away that get from that age, I feel like that is a good age period for young adults. And so it's kind of this emerging adulthood in young adults. So, and some of the things that I'll kind of discuss is we hope, and we're planning on looking at the race ethnicity in the future analyses, but because of looking at, and using the 2021 data, we don't have the DOH breakdown in race and ethnicity. And so we're kind of waiting, to kind of look at that, because as we know in the state, it's really important to kind of look at that kind of breakdown further based upon just kind of the census kind of breakdown. And then going to zero in on the young adults and look at these models for some co and poly use, have some predictive models for if individuals are using in particular ways, and how that predicts whether or not they would co-use for other substances. And then look at some mental wellness and mental health kind of aspects, particularly depression. So for the future, we're kind of also hoping on looking at some aspects around like community and school-based kind of location, physical health, and how co-use and poly-use kind of relate. And then also we had started to look at, but I don't think I'm going to have time, so I figured that might be better to kind of bring in later, but talking about some of the adverse childhood experiences related to co-use and poly-use. So quickly, so the behavioral risk factors surveillance survey comprises an annual statewide telephone survey, which is landline and also cell phones now, of all kind of adults age 18 and older. And it's part of a larger national survey coordinated by the Centers for Disease Control and Prevention. So the CDC is the one that kind of like really pushes hard to kind of do this national survey. And Hawaii is one of the, it's the state and kind of District of Columbia, and also tribes also participate to kind of get a full kind of comparison for the US population. The prevalence, really some of the questions really focus on health behaviors, medical conditions, risk factors, and then preventative health practices. So going to the doctor, seeking medical care. So there's a core module that tends to be regularly utilized, and then there's optional modules and also state added questions. And last thing I'm going to note is that the data is weighted by the CDC to kind of adjust, for the probability of selection. And so there tends to be 8 kind of demographic variables that kind of is based upon the source, if it's the landline or cell phone, race, ethnicity, education level, marital status, age by gender. So maybe, we had more males in the older kind of age bracket, and so we wouldn't want that to kind of be overrepresenting. And so they do an age by gender, a gender by race ethnicity, age by race ethnicity, and then renter owner status. So that then, and that becomes important when we start looking at the data, because I'm going to present the raw numbers, but then also present the weighted percentages. Okay, so we're using the 2021 preface partly because the cannabis questions have only been asked for these 2 years so far. And so we also kind of wanted to kind of present out on some of the most recent data available. And so the other thing that is kind of important is the poly-use considerations. Well, cannabis use is asked about in the past 30 days, and so is alcohol use. But nicotine or tobacco use tends to be worded differently, and I'll kind of show the questions here in a minute. And so we had to kind of make a call on co-use and poly-use categorization, partly for the tobacco and nicotine questions. And so when we start thinking about the prevalence of these, well, I'm going to talk in the past 30 days, kind of more of just generally, but just know that tobacco and nicotine, don't ask it in the past 30 days. It's kind of the way that they ask questions. But because we're using the 2021 data, we're using the CDC release data sets. And so, you know, in the next few months, we will be putting in a data use request to kind of get the race ethnicity breakdown for the state. And so that we can look at some of those as well. And then also kind of by location. So looking at some of the community and school-based locations. So we don't have any race ethnicity kind of breakdown that we would be interested in for Hawaii. It's mostly all the census breakdown, but we do control for that in some of our analyses. All right, so some of the questions, just in case if you're not familiar. So for the alcohol question, we tended to use the question around during the past 30 days, how many days per week or per month did you have at least one drink of alcohol beverage, such as beer, wine, or malt or liquor, or a malt beverage or liquor? And so with that, we tended to use and put this into kind of a yes or no. Yes, they've had alcohol in the past 30 days or not for the analyses that we're going to kind of present. We did kind of do some other breakdowns, but I'm not going to present on that today. For cannabis, similar. So during the past 30 days, on how many days did you use marijuana or cannabis? And so we're going to kind of talk about the yes or no and kind of look at that. This is where things get a little tricky. So for combustible cigarettes, there's this question that kind of guides then the skip logic patterns. And this is, have you smoked at least 100 cigarettes in your lifetime? And if so, then you get the next, do you now smoke cigarettes every day, some days, or not at all? And so we took this question for the combustible and took every day and some days to be kind of like, okay, that's likely that's kind of going to be the overlap for our 30-day with alcohol and cannabis. And if you're not at all, we group that in with the, okay, so the individuals that have never smoked 100 cigarettes, that's the never smokers. And the not at all to this question is likely former. And so that's, we're going to get this kind of weird never former kind of category. And that's why when we start talking about the data. Some similar things with the vaping, they ask kind of a skip logic of, have you ever used e-cigarettes or other electronic vaping, even just once in your lifetime? And if you answer yes to that, then you get this, do you now use e-cigarettes? And then every day, some days, or not at all. So we have this kind of never or maybe former if they answer not at all. So this kind of way that we broke this down. And then we had other nicotine products that we looked at in here. And so chewing tobacco stuff, so every day, some days, or not at all. The other questions that we were interested in and that we looked at was the mental well-being and mental health, focused on depression. So that first question around mental kind of health, around stress, depression, problems with emotions during the past 30 days, we grouped that based upon the recommendations on if 0 days, then, you know, we looked at that. And then we have the 1 to 14, and then 15 and more days mental health was not good. And so then that's kind of the poor kind of category that we'll talk about here in just a minute. And then have you ever been told that you have or had a depressive disorder? And so we'll look at this when we kind of towards the end on some of the predictive models. All right, so let's look at some of the data. And like I said, this is kind of some things that we've been recently working with. And this is for all ages now, going across, and I mentioned the column on the never former. This is based upon that question around the smoking, vaping and smoking. So we have that former kind of part of this. Some things worth noting here is that when we look at the total columns across all of these tables, it will be the column totals. So across all these age groups, we'll see these will be kind of going down. And then when we're looking at the substances, so like any nicotine use, this is kind of going across for 18 to 24-year-olds. So any that are using nicotine is at 26.58%. Alcohol was 44, almost 45%. And then any cannabis is 15%. And so we can kind of see, you know, for the nicotine, you know, this tends to be highest kind of up until mid 40s, and then we start to see some decline. Same thing with alcohol and cannabis. So we definitely see some patterns that are kind of going on here. Now, I'm just highlighting things because these are kind of things that are striking us as we're kind of looking at this. We have not looked to see if we have proportional differences across any of the age groups, but these are things as we kind of look at some of the data that's kind of drawing our attention. So I wanted to highlight some of this. And so this table gives us kind of the whole spectrum across the age groups. And so we can kind of look, you know, and this doesn't kind of present any of the co-use data yet. It's just any nicotine, alcohol, or cannabis. So we're seeing young adults tending to have a higher proportion, which is kind of what we would expect based on some of the literature. If we look at the down below male sex, so in the never, we're seeing the overall population that was looked at for this. Males tend to be lower for this never former kind of category compared to females. But we'll also see some interesting patterns come out with males and females when we start looking at young adults. So that's also worth noting. So because we have less males kind of in this never former, there's more males using nicotine, alcohol, and cannabis going across. And so that's worth noting. Now, this is the whole entire population. So this isn't sex by age or anything. So it's all males and all females that were participants in this. Okay. Now, there's a lot going on here, so I kind of want to take a moment to kind of look and break this down a little bit. The categories here for poly use, nicotine and cannabis, alcohol and cannabis, alcohol and nicotine only, alcohol only, and cannabis only are all mutually exclusive. So you can't be a poly use, like you can't be in the poly use and then also be in the nicotine only. So hopefully that, you know, makes sense. So, you know, the numbers start to kind of break down smaller and smaller because these are mutually exclusive kind of categories. So that's something worth kind of putting out there. Now, let's see. Okay, so drawing in and kind of focusing on, you know, the 18 to 44 kind of age groups, polysubstance use, you know, we kind of see highest in some of the younger age, 18 to 24, and then slowly kind of tapering over the age kind of groups. And this is the same. We do see that like nicotine and cannabis is a slightly higher for the 35 to 44-year-olds for that co-use of those two substances. You know, and so that's looking at some of these numbers, you know, we can see these are weighted. So if we take 18 to 24-year-olds and we look across the poly, nicotine, all of this, and so if we go across and we add those up, and then we take in total like the 18 to 24-year-olds that are the never former group, we would have 100% across this. But these are weighted based upon the CDC's. So you know, if you do the calculation, it's not going to be an exact to that. Like poly use for 18 to 24-year-olds at 6.13. All right. So let's kind of zero in. That was across the full age spectrum, looking at males and females across the full age spectrum. But let's focus in on the young adults, the 18 to 29-year-olds, and see kind of what we got going on. And so if we look at past 30 days, now, again, I'm going to kind of use this, even though we know that nicotine, it wasn't asked in the past 30 days, but alcohol and cannabis definitely were. Half of the individuals from 18 to 29 are kind of using alcohol, any kind of alcohol in the past 30 days. So this is like 52%, just under. The other, nicotine. So combustible vaping or some other nicotine product is 1 in 4. And then for cannabis, any cannabis type of use is 15%. And so this is kind of important to kind of look at, because this is the any alcohol, any nicotine, or any cannabis for young adults. And so these really are not mutually exclusive, like we're going to see here in just a second when we look at the breakdown. So here's the breakdown of poly use. And so when we look at the 3 substances kind of, and this is for the questions of like recently, you know, in the past 30 days, 1 in 20 individuals are using all 3 substances. So they're really kind of current poly users. So the same kind of for alcohol and cannabis. You know, we got like 1 in 20 individuals are kind of co-using alcohol and cannabis together, you know, within the past 30 days. And then also, like when we look at alcohol and nicotine, it's higher as 1 in 10, you know. And so the thing that's really important is, as I mentioned, some of the risk factors and harms for poly use and co-use tend to go up. And so these are some of the reasons why we worry about the poly and co-use going on. Now, if you would take so for example, if you wanted to know, okay, so we've got 2.6 cannabis only. Well, what does that mean? Well, if you take the cannabis, you want to know how many were the cannabis users. How did we get the 15 from back here? Well, you could take the nicotine and cannabis, or the poly use, the nicotine and cannabis, alcohol and cannabis only, and those would all add up to the 15. And so that's kind of where that number of all cannabis kind of comes from when looking at this, as these categories are mutually exclusive. All right. So here's young adults looking at singular, co-use, and poly use. And there's something interesting, I would say, here. And as we explore this a little bit more, I think it's worth noting that in the single use kind of these 3, we're not seeing differences between males and females. It's when we get into the co-use and the poly use is when we're starting to kind of see some differences going on. And we're going to explore that statistically here in the coming months. And we'll be kind of working on kind of a report to kind of talk about some of these findings. And so stay tuned on some of that. So let's look at some of these sex differences between males and females, and kind of what we have going on, you know, on the sex breakdown and the mental health breakdown. And let me point in, you know, zero in on some of the interesting kind of findings here. So males, we're seeing definitely kind of a higher poly use. Alcohol and nicotine, we're seeing definitely some higher the prevalence is higher for males for alcohol and nicotine, also nicotine only. And so those things should be something that should draw our attention when you think about nicotine use, and looking at male kind of patterns for nicotine for combustible vaping and other products. The other is, and this is something when looking at the alcohol only, so females actually tend to have, or kind of higher in this category of alcohol only in that respect. Now, you see there are some cells I suppress, but if there were kind of like in a direction, I just also highlighted those to kind of note. For the mental health, so we looked at this yes or no kind of for the depression. Have you ever been told that you had a depressive disorder? And some things, you know, that we're seeing for polysubstance use is higher prevalence in that kind of the proportions are higher for alcohol and cannabis, and then poly use. And so we actually kind of have a logistic model that will discuss that a little bit more. And we also kind of then did a similar look for the number of days mental health was poor. So if they had 15 or more days, we categorize that as poor. And so then we can kind of see, you know, going as we keep going up in the number of days, we see that this is also kind of associated with higher rates of poly use across the three, and then also kind of higher rates with alcohol and cannabis. So, all right. Well, let's kind of look at the co-use, really kind of zeroing in on the nicotine and cannabis as we look at the co-use kind of patterns across these. And so we have some logistic models looking and using the no use or kind of the former use as the reference group. And depending on whether individuals use some type of nicotine product, and we broke this down and we took out the other nicotine products and just kind of looked at combustible e-cigarettes or whether or not they use both. So now we're kind of looking at the dual use of nicotine products, particularly e-cigarettes and combustible, kind of in this both, with all the other kind of being filtered out. And what we see compared to those that never use is those that use e-cigarettes, they're 2.4 times more, the odds are higher for them to use cannabis in the past 30 days. For combustible, it's 3.2 times the odds. And then if they're using both, the odds go up by 7.2 times. And so this is really worth noting here. Well, now we're looking just at like the dual use, this is just nicotine products, but the dual use of vaping and combustible even takes the odds up for cannabis use in the past 30 days. And so really we're starting to see the more substances that are getting used, it tends to improve the odds here. Now we did control, I will say, for sex, preferred race, and education level kind of in these models. So because we were kind of interested in this, like, okay, well, so that was all compared to whether or not someone wasn't using. How does it compare, e-cigarettes, someone vaping compared to combustible cigarettes, and then if they use both on predicting whether or not they've used cannabis in the past 30 days. Now, we didn't see any significant difference between e-cigarette use and combustible cigarettes. The p-value being at 0.2, but compared to their use of both, we did see that there was 2.76 times the odds using cannabis in the past 30 days. Again, controlling for sex, preferred kind of race, and then also education level. And so this is something when we're looking at some of these substances and how they can combined for increasing risks and harms, these are things worth kind of taking note of for prevention. Kind of did the same thing for alcohol and cannabis, and what we found was, we looked at alcohol in the past 30 days, yes or no, and what we found was that if individuals used alcohol in the past 30 days, they were 3 times as likely to also use cannabis in the past 30 days. We also looked at this for binge drinking in the past 30 days, and that's drinking 5 or more drinks in one episode for males and 4 or more drinks in one episode for females, and found almost the identical kind of the findings here. Odds were almost identical as well. So very similar. These substances are kind of being co-used. If you use one, the odds go up. Well, looking at the co and the poly use for mental health, this was a little tricky, partly because we have a lot of co-use combinations. And so what we did was just look at, well, if you singly use one substance versus co-use versus use all 3. And so that co-use is all 3 of the combinations kind of together. So it's just taking it kind of like in this order of like, well, do you just use one of these substances? Do you co-use 2 of these substances, or do you use all 3? And how does that relate to this idea of being told that you have been had a depressive disorder? And so compared to never or former, individuals that use at least one substance were had 2 times the odds of being or told that they have a depressive disorder. And so that's something worth kind of taking note of. Okay, single use, we would want to kind of zero in on and we'll kind of try to later tease this out with analyses of what substances. But as we kind of go and start looking at co-use, okay, well, so now it rises to 4 times the odds. And then poly use of all 3. If you're using all 3, it's 10 times the odds that you have been told that you have a depressive disorder. So this is, I think this is the last slide for the data. And I think this is the kind of like why it matters. As we start to see going from single use to co-use to poly use on how this is related to mental health is really influential in thinking about why this is such an important topic. So it can really help us think through like some of the priorities for communities, identify some of the high burden for emerging adults and young adults, marginalized groups, which we're hoping to kind of then look at the race ethnicity once we kind of get the DOH kind of breakdown for race ethnicity and kind of look at this a little finer grain. And co and poly use sometimes gets less attention. Even, these are like 3 kind of widely used substances. We didn't even look at misuse of like prescription drugs, meth, we're just looking at the 3 kind of most commonly used substances. So, and for prevention programs, there's a real need to assess this idea, especially for prevention intervention, co and poly substance use, to really think about targeting programming. And so I think that's really important. And kind of this area around, for tertiary kind of prevention and treatment services, there's a great need to address the multiple substance use early on, partly because, as some of the other researchers kind of pointed to, in later adulthood, it becomes harder and harder to address substance use disorder with co-occurring substance use or alcohol use disorder diagnoses. And also we find it's tougher then because also we have these co-occurring mental health diagnoses. So this can really help, the data can really help kind of inform and drive how we think about some of this from a system-wide kind of policy discussions going on. And so that's some of the things that really I think is important. Well, thank you. Appreciate everyone being here and take questions.
Great, thank you, Dr. Phillips. We're now moving on to questions. So go ahead and use the Q&A feature or raise your hand.
Okay, we have one question from Sarah Yuen again. I will unmute you right now.
Hi, Sarah.
Hey, thank you, Michael. This is a very interesting analysis. I wonder, for from the prevention point of view, as we see that most of the young adults actually they use alcohol alone, especially females, and but then there are also uses 2 or 3 substances, especially for male. Are they usually is alcohol usually the what they call the entry, the first drug or substance that they use, and what age do they start to use? And we know from other data that they start really young, right? But when
12, 13. Yeah.
Right. So from the prevention point of view, what is the significance of these, understanding the poly-use or dual use issues?
Yeah, great question. And, I think, so we're going to try to take a look at some of the youth, data. So the YRBIS, the youth risk behaviors, and kind of do some similar things because they ask about initiation of some of these substances. And so we're going to kind of really try to do some of those analyses in the next coming months, probably around the co-use, because I think that's an interesting question, because so much of the time we look at age of initiation for these substances, but we don't always look at how the patterns play out as far as co-use and poly-use of age of initiation. And so I think that's a really interesting question of like, well, which one is being initiated first? What are some of the patterns looking like? If co-use is initiated, then kind of going on, and this is where longitudinal data is really kind of needed and important is, well, what becomes kind of the more regular kind of maintenance use across time after, these, so is it alcohol being used first and then tobacco that we then see later on more lengthier kind of co-use patterns, and so I think that becomes really important to study. So it's a really good question because it really gets at how do we need to be thinking about co-use for these middle school. A lot of times, like as Scott pointed out, I mean, middle school is such an important kind of period to kind of be making these school-based and community-based prevention programs. And so looking at these patterns and then really providing that information to these prevention programs to really kind of understand how these kind of play out longer term is so critical.
Thank you. Yeah, and the these public data sets, they don't measure to the extent that whether these people are really dependent on these drugs, or they just recreational use, right? So and there is also maybe important to look at those too, and those data are not necessarily available.
Yeah, and I think that's important to understand. Just because someone is co-using doesn't mean that they're going to end up with a substance use disorder, right? I mean, that's something I think that's important, because this data does not provide, any information around substance use disorder. Now, there are some of the indicators of like binge drinking in these data sets, and heavy drinking, in the past 30 days. So, I mean, can look at some of those things, but we don't know a lot of the negative consequences, that have happened in relationship to their substance use. And I think that is a crucial thing to kind of have and understand. So, yeah, I mean, it's then where having other data sources, kind of looking at the emerging adults and young adults, kind of really getting at some of this, where these patterns are getting set early on, is really, it's important to kind of understand.
Thank you.
Yeah, good question. Hopefully we'll be able to kind of glean some insight from some of the younger adult data sets, but again, we're limited based upon the questions that they ask.
It is a really good start, to look into this, and yeah, really interesting data. Thank you.
Yeah.
We have one question from the chat. What does the data say or infer about marijuana vaping?
Oh, good question. And so, Scott, we started to kind of take a look, being that this is, the 2020-2021 breakfast data is the first kind of go at Hawaiʻi asking these cannabis questions. And so we started to kind of do the breakdown of, because it asks, there's like two other follow-ups of like, what are some of the kind of reasons, and so being medical reasons, or for recreational, or for both, and then also how they're ingesting it. And so vaping is one, vaping, smoking, edibles. And so this is something that we hope to explore. We've kind of played around with this a little bit, in the data analyses, but we need to kind of keep working it through. So it's something that we should be able to kind of pull together into a data report for this year. So good question, because it is something that we're curious about too. We looked at the whole idea of co-using combustible and vaping tended to predict higher past 30-day cannabis use. So that was an interesting thing that we kind of found, but no difference between combustible and vaping cigarettes, or vaping nicotine. So wonder how that's going to play out when we start to look at vaping nicotine and then vaping cannabis, if there will be some differences. See, Tanya asked the question here, is there a reference module that gets at those issues? If so, that might be possible to look at adding it. It'd be, I haven't seen any of the modules that would are you talking about the substance use kind of disorder aspect, Tanya? Like any questions to get at? Oh, that's good. I'll have to make a note of that and take a look. I haven't seen any of those optional modules that get at, but that doesn't, we've had conversations. I don't know all of the modules all that well, so I will take a look, because that would be a good thing to kind of take a look at and see if we could add that in coming years. It might be kind of an interesting thing to kind of go into around and connect, if there are the questions, or some questions of, have you ever been told, that you have a substance use disorder, that type of thing from a medical professional. I'm not sure. So I made a note. I'll kind of follow up with you. Good questions. A lot of things that we've been pondering ourselves and trying to peel back some of the layers on these things. So thanks everyone for some of these good questions. Any others? We're going to be working hard to put out a report this year on some of this co and poly use. So SEOW will be working on kind of pulling that all together, just as a FYI. Thanks everyone. Appreciate everyone coming, and I know Laura has a few announcements here to make because we want to be checking in with everyone here in the upcoming months.
Yes, thank you so much for our speakers for the great presentations. We just have a few closing remarks. So we are working on updating our SEOW member list. If you have been a previous or a current member, you'll receive a membership form to ensure we have an accurate list of members. If you would like to be a member of our work group, or if you would like to refer someone, please email us. We'll also be reaching out to SEOW members and prevention providers to get feedback for topics of interest. So please contact us also if you have, if you'd like to suggest a specific research topic. And our next SEOW quarterly meeting will be on May 31st, 9 a.m. to 11 a.m. on Zoom. And we would like to ask everyone to please fill out our brief post-webinar survey that'll pop up once you exit the Zoom room. We greatly appreciate your feedback on the meeting. And if you have any ideas for future speakers who will be willing to share data related to substance use, please let us know also by email. We'd be more than happy to talk to anyone that you feel like would be a good fit for our meetings. And that concludes our SEOW quarterly meeting for February 2023. We'll see you at our next meeting in May. So thank you, everyone.